Alright, everybody, welcome back. So last time we talked about the pulmonary circulation, something we've pretty much been discussing ever since we started respiratory physiology. Very big deal, very important topic. We got to revisit this little snippet on the top right from something we talked about in the very first physiology video of respiratory. So this wasn't so bad at all, right? And they had an equation here that you could add onto your cheat sheet if you want to, or if you already have good knowledge of it, then you don't really need to worry about it too much. But this equation is more important as a concept rather than it is as an equation. Right? So diffusion in the alveolar area of your lungs, how does that all occur, is based off of the area times dk, which is the diffusion coefficient of gas. They have to give you that. You don't need to memorize that. Multiplied by the difference in partial pressures divided by the change in delta x. So delta x is actually something that is going to be based off of various different factors. And you can see how two things here change. So delta x is something that increases in pulmonary fibrosis, which means that if this is increasing, then you're dividing this entire thing by a bigger number, right? So let's say P1 minus P2, the difference in partial pressures might be something like 10, right? And if delta x is supposed to be 2, then 10 divided by 2 would be 5. And that's going to be a bigger number, and then you multiply everything across, so that makes your V gas bigger. But if your delta x becomes a bigger number, like maybe 5, then 10 divided by 5 would just make this 2, right? So delta x is something that increases in pulmonary fibrosis, and when that occurs, diffusion becomes lower, right? So the main thing to understand here conceptually is that your diffusion V gas is indirectly related or inversely related to delta x. And we know this, in pulmonary fibrosis, diffusion doesn't occur very nicely. The other thing is your A, this thing, the area. The area decreases in emphysema, right? And again, area looks like it's directly related to diffusion. So if area decreases and you have less area for diffusion, then of course diffusion also decreases. And I've never really seen a question where they directly ask you something about this equation per se. It's just a conceptual thing. It helps you understand what's happening. The other thing was this set of numbers. This is something that you need to drill into your mind, throw onto your cheat sheet until you've mastered, and so on. Right, so the big A is for alveolar, and the lowercase a is arterial. Right, so that's the first thing you want to make sure you know. And your alveolar oxygen is supposed to be pretty high, right? Because you have a lot of oxygen in your alveoli. That's kind of how they function. Your alveolar oxygen should be really high, and then your arterial oxygen, when it first arrives, should be low, and then when it's finally done with the gas diffusion and stuff, it becomes much higher. Right? So that's why there's two sets here, how it's going to be initially and how it's going to be after. So this is kind of more so like venous versus arterial, if anything, something like that. All right, and we're going to see that. So let's delve into where we left off. So the first thing we have here, pulmonary vascular resistance, PVR. This is something you can have to calculate, but this is literally the difference between your pulmonary artery and your left atrium, those two pressures, divided by cardiac output. This is something you might have to memorize if it doesn't make complete sense to you. But what we have already seen is stuff that we saw when we were in cardiovascular. Right in the beginning, we saw this equation, right? Resistance is equal to delta P over Q. The change in pressure divided by flow. Cardiac output, right? Cardiac output, flow, same thing. And then we know resistance is inversely related to radius raised to the fourth. So any change in the radius has a fourth power effect on resistance. And that's something that often gets tested. This is, of the equations on this page, this is the thing that you can get a question on most likely. All right. But pulmonary vascular resistance is going to be important because later on you're going to see questions about pulmonary hypertension. We've already seen a lot of that pulmonary hypertension stuff when we were doing cardiovascular. We saw in renal. It's a thing that occurs due to many reasons, many different issues. We even saw it when we saw obstructive sleep apnea related stuff, and I think we're going to see a lot of that here now that we're in respiratory, because sleep apnea is about breathing incorrectly while you're sleeping, and that can be fatal. That can be fatal too. So pulmonary artery minus the pressure in the left atrium, that's the difference in pressures in that area, divided by cardiac output. Very straightforward equation. The other thing, alveolar gas equation, this is something that we've worked with when we were much younger. Back in high school, there was a very important need to know this, the alveolar gas equation, when we were doing chemistry. And there really wasn't any real life application of it per se at that time, but you do need to remember these numbers, right? So this set of numbers is pretty significant even for this section right here, and it's going to be significant for questions as well. When you have to tackle questions later on, we're going to see on step 1, for example, you can get images like this. You can get one of these where the number in the vessels can change. Right, so in the middle I had the normal numbers, but those numbers in the vessels can change to pathological numbers, like here it's 70, right? All of these are 70, and that's how you have to kind of understand something's not right, right? Over here it's 40, that's the lowest so far from all of these questions. So it's going to be a while before we see that right now, but that is going to be something that you have to memorize. Now, alveolar gas equation, don't worry about it too much. Just give it a little bit of time, check it out, but that's about it. There really isn't much you have to do with this. Let's take a look at this question, and then we'll delve into whatever's left in respiratory physiology now. So this is a question from USMLE like 2 years ago. Physiologist divides the lung into 3 zones, with the apex being zone 1, the middle region being zone 2, and the base being zone 3. In an experiment, the physiologist applies a small amount of positive pressure ventilation while studying blood flow in different lung zones. Which of the following will be noted in the experiment, assuming the subject is standing? Now, this topic is something we're going to see soon when we get to VQ mismatch. And positive airway pressure, or PEEP, right, positive end expiratory pressure, all of these things are starting to become a little more prominent in step 1 now. It wasn't such a big deal in the past, but now in step 1 and even in NBMEs, asking questions about PEEP and positive airway pressure, which is PAP, I guess, is becoming a much more big deal now. And even USMLE RX, in their new Q bank, they have a bunch of graphs, a bunch of very intimidating graphs where they kind of show you how to deal with positive airway pressure questions and whatnot. So I'm looking at those with another student right now, and that's going to be something new in these videos too. I'm going to try to add that into the path section of respiratory, so that I can discuss it with you guys and show you guys how to tackle that, because some of those graphs were actually pretty intimidating. Like, even when I looked at it, it was like not intimidating to me per se, but it was weird to me because there were too many lines being put into the same graph, which is kind of what medicine does. It's kind of stupid that they do this. You don't need so many lines in the same graph. You can make separate graphs for each of these, but they combine all of these graphs just to make life harder and then try to see if you can get the question wrong. So you just got to be careful. But this topic of zone 1, 2, and 3 of a lungs of a standing person, right? So you have your top, the middle, and the lower portion of a lung, is a pretty common physiology thing that you do have to understand. So while he's standing, they're applying a small amount of positive pressure ventilation, right? And positive pressure ventilation has to make sense to you. So before we even look at what's happening here, let's take a look at what we've been talking about in terms of pressures, right? Because we've been talking about pressures forever. And Respiratory 5 and 6 did an amazing job in those videos, helping you really understand how these pressures mean something and what it means for pressure to be increasing. How does that help you breathe? How does it help you breathe out? Stuff like that. So positive airway pressure would basically mean that the line's going up, right? So pressure is increasing. So you can see how during inspiration, though, during inspiration, pressures decrease, right? Pressures decrease. So that means that they're applying positive airway pressure, they're making this guy breathe out, right? That's something you want to make sure you understand. When you have positive airway pressures, that means there's a lot of pressure inside your lungs, so you're going to force air out of it, right? And negative airway pressures are going to help you breathe air in, which almost never occurs. You don't really do negative airway pressure per se. So here they're asking what would happen if the person is standing, and they have a bunch of answer choices. Here the correct answer was blood flow will be reduced in zone 1. And this is just a straightforward thing. You actually don't even need to know what's happening in the question. This is just a concept of the fact that if you're standing, right, why do we naturally have a ventilation perfusion mismatch? And that's what we're going to be coming up to right now. So this is a good introductory question. But ventilation is basically air, right? You breathing in. And perfusion is that air going into blood, right? So perfusion is blood, ventilation is air. When you're standing tall like this, blood is going to be at the base of your lungs, right? So that's going to be zone 3. Zone 3 is going to be where most of the blood goes. So zone 3 is going to have the highest perfusion because obviously gravity just pulls the blood to the lower part of the lungs. Not a lot of blood in the top parts, the apex of your lungs, right? Zone 1 is not going to have a lot of perfusion. But zone 1 will have more ventilation up here because, of course, air can go into your entire lung. However, ventilation is also pretty high at the bottom, right? But there's just much more perfusion and then there is ventilation. So ventilation isn't quite affected by whether you're standing or laying down, right? Because when you breathe air in, you send air to your entire lungs. But blood is usually at the base of the lungs, not at the top because of gravity. Right? So there will always be a VQ mismatch if the subject is standing, and arterial blood flow will be greatest at zone 3 due to gravity. Enhancing ventilation via positive pressure ventilation will further increase this VQ ratio because alveolar pressures increase and compress the arterioles, leading to reduced blood flow in zone 1. Right? Every time there's a lot of air in your lungs, remember those alveolar vessels constricted, right? That was something we've been looking at since forever, now that we've been talking about this. But when you have air coming in, remember inspiration, air coming into your alveoli, the alveolar vessels constrict because now those blood vessels are full of air and you have to constrict it to send blood away from the lungs and to the muscles and brain and so on. So that's something you want to keep an eye out for. The rest of this here was just extra notes I put for those who bought the book and whatnot to better understand Dalton's law and the equations that we had earlier, which is Fick's law, right? This equation that we had right here, this one, the diffusion gas equation, is basically Fick's law from chemistry and physics. The same exact thing. The diffusion was related to the area, the thickness of the barrier, and all of this was being affected, right? Area was decreasing with emphysema. Thickness of the barrier was increasing with pulmonary fibrosis, right? That's what this delta X down here is, right? Alveolar wall thickness. So that's something that you can always feel free to pause here, check out what's happening. But the numbers are labeled here too. So this was a pretty nice graph from like another book. A very nice graph showing you all the inspired oxygen going down your trachea, reaching the alveoli. The alveolar oxygen is 100. Alveolar CO2 is 40. You have to memorize that. Now, when the venous blood comes, right, you drop off CO2 into the alveoli and pick up oxygen into the arterial blood. Right, so then it should match. It should take on the same numbers. Right, plus or minus a little bit, but generally speaking, it should be very close. Nothing major of a difference. If there is difference, then you could have some kind of lung or alveolar problem. Right, now, this is a separate topic that, although first aid kind of discusses, it doesn't do such a wonderful job talking about it. So I inserted this from UWorld into the physiology section to kind of talk about it and make sure you totally understand what this means when such a thing is presented in a question, for example. So, pulmonary auscultation examination findings. Let's take a look at this UWorld question. A 53-year-old man comes to the emergency room due to progressive shortness of breath and non-productive cough. Medical history is significant for long-standing hypertension and type 2 diabetes, for which he takes lisinopril and metformin. The patient has no drug allergies. Blood pressure is pretty high. Pulse is 11. Respiratory rate is 20. On physical exam, heart sounds are regular, so that's good. Lung exam reveals decreased tactile fremitus over the lower right lung, along with dullness to percussion. Right, so decreased tactile fremitus and dullness to percussion. What is the most likely diagnosis, right? And they're doing this at the lower right lung. So now, either you have enough understanding of everything and you would know it's pleural effusion, or you could pick pleural effusion based off of the decreased tactile fremitus, right? That's going to give it away. So how would you know this? Well, if you don't know this, then you can fuck up and pick what the other 30% of people chose, and 30% of people messed up and chose lobar consolidation. Had they known this, the number of people getting this question correct would have gone up to 77%, maybe even more, right? So this patient most likely has a right-sided pleural effusion. Why do we know this? So let's take a look at this table and understand. The first thing here says normal stuff. So if your lungs are normal, then breath sounds should just be normal. Tactile fremitus will also just be normal, and percussion will have resonance, right? So percussion, you want to think of percussing the strings of a guitar, right? So when you percuss a guitar string, it resonates back and forth and you hear it, right? And that's kind of what's happening with our normal lung too. Percussion will be heard, right? Because there is air in your lungs, and air is necessary for those percussing waves to be heard. Tactile fremitus is like knocking on a wood or something, and you should be able to hear just normal sounds. Nothing too high, nothing too low. It's just like you're knocking, so you heard, right? You heard sounds because you were knocking on it. nothing motion. It's tactile, so you can always remember tactile has something to do with actual tactics, moving, right? So it's knocking. It's kind of just knocking on the different parts of your lung and listening to what you hear. So now, based off of how these things change, these can give away disease to you. Notably, right, not all of these are extremely important, but notably these give you very, very specific answer choices actually. These things will actually give away exactly what the problem is. As you can see, right, tactile fremitus is only increased in one case scenario. Only one case scenario. So if a question ever tells you that tactile fremitus is high, right, let me see, what is this? Fill it with, oh no, I didn't want to do that. Hold on, 1 second. Where's the open one? There you go. Should be open. And no? Okay, never mind then. But yeah, what I'm basically trying to tell you guys is that the only time it's increased is when you have consolidation, right? So if you ever hear someone in a question stem tells you that tactile fremitus is decreased, that doesn't really give away an answer to you, right? Because you can see it's decreased in 3 separate scenarios here. So the only time it's increased is in consolidation. Why? Consolidation is pretty much something solid. So when you knock on something solid, the sound is much louder than on just your normal lungs. In the other case scenarios, you either don't have a lung anymore or you have fluid in the lung, right? So your fluid in the lung is pleural effusion. These 2 case scenarios don't have an actual lung in a way. I mean, in atelectasis, your alveoli all blew up in a sense, and in pneumothorax, your lung is about to blow up. So you don't have any lung or you have fluid in your lung. All of those case scenarios decrease the amount of knocking sound you can hear. All right, so that's one case right there. Increased tactile fremitus, pretty much a giveaway for consolidation. With percussion, you can see it's dull everywhere, but it's a giveaway for pneumothorax. In pneumothorax, what happens is that your lung is gone, yes, but you have too much air. So much air that the resonance becomes hyperresonance, right? And the other thing is, it's not just air, but it's actually air outside your lung, right? So it's air outside the lung, but still behind your chest wall. So the resonating sounds are very, very direct in a sense, as opposed to the air inside the lungs resonating, that's a little less louder. Right? So hyperresonance, if you ever get a question where they tell you there's hyperresonance to percussion, that's a giveaway for pneumothorax. All right. The other case scenarios, pleural effusion and atelectasis, they both have decreased tactile fremitus and dullness to percussion, which is pretty much our guy's case, right? Our guy has decreased tactile fremitus and he has dullness to percussion. But there's a difference between pleural effusion and atelectasis. Pleural effusion, they told you this is only occurring in the lower right lung. If it's occurring in one area, lower right lung, well, you know that in the lower right lung or the lower parts of the lung is where pleural effusion goes. You just have fluid pretty much sitting at the base of the lungs right on top of the diaphragm. Atelectasis, this would be the entire lung basically, or a huge portion of the lung at the very least. Right, so that's the main difference between these 2 diseases. Even though they present similarly on auscultation, they're completely different scenarios to begin with, right? So it's not much to overlap there. And the rest of this is just me explaining this a little more, but you should have a very good understanding of this, right? Don't let this kind of stuff slip away, because this will give away an answer to you. It will make things so much easier, right? There was no reason for anyone to pick lobar consolidation, because you know that in consolidation, tactile fremitus would be increased, not decreased, right? So knowing all of this really helps you knock out answer choices too, which is just as important as being able to pick the right answer choice, right? Both of those things are a very important skill to have. This here is an AMBOSS question, and only 17% of people got this right, because this is something that another one of those bullshit topics that step 1 has been picking on a little more. Step 1 has been picking a lot on 2 things in the thoracic area. The entire lymphatic drainage of things here, right? And then this kind of silly thing. So this one says, a 47-year-old woman comes to the emergency department after coughing up 2 cups of bright red blood. A CT angiogram of the chest shows active extravasation from the right bronchial artery. A coil embolization is planned to stop the bleeding. During this procedure, a catheter is first inserted into the right femoral artery. Which of the following represents the correct subsequent order of the catheter route, right? So straight up, in a sense, just anatomy. So a catheter is inserted in the right femoral artery. Where is it going to go from there? Well, from the femoral artery, you know it has to enter the thoracic aorta. That's what we're trying to get to, right? We're going up the legs into the aorta. So that part was easy. It was after the thoracic aorta that it was difficult for people to pick correctly. So what's happening? So I got this image on the right side to kind of help you see it, right? So we all know about the intercostal arteries, right? Those intercostal arteries were a big deal in people who have coarctation of the aorta, right? Because those intercostal arteries that are under the ribs all become very important for collateral blood supply, right? Blood goes around the ribs and then comes down into the descending aorta because there's a coarctation here that doesn't let blood flow down. Right, so that part we've seen before. The new thing here is knowing where the right posterior intercostal artery goes into the right bronchial artery. Right, that's something that I didn't really know much before either. But the main thing is the left bronchial artery, you can see here, pretty much comes right off of the aorta. Right, but the right bronchial artery comes off of the intercostal stuff. And that's probably because the aorta is on the left, so it's closer to the left lung as it is opposed to the right lung. So that's the stupid little topic of anatomy that they wanted you to know. So the bronchial arteries supply the lung tissue with oxygenated blood via the systemic circulatory system. So this is blood that's being given to the lungs, not for the lungs, but to the lungs. There's a difference. And this is true about your heart too, right? Even though your heart works with blood all the time, that blood is not for the heart to use, it's for it to actually send out to your body, right? And then after systole occurs, during diastole, some blood comes back from the ascending aorta and goes into your actual heart itself to supply the heart. Sure, you can ask about anything. Ask whatever you want. So now here, what we're talking about with the bronchial arteries is that how do you get blood to the lungs, right? Because so far we've just been looking at all this blood going into the lungs, but it wasn't for the lung to use. It was blood for the lung to just give it oxygen, and then you send the blood away from the lung again. So now here, these bronchial arteries, these are the guys that kind of supply blood for your lungs to be alive, right? Basically give nutrients to your lungs. The bronchial arteries supply the lung tissue with oxygenated blood via the systemic circulatory system. The right bronchial artery most commonly originates from one of the intercostal arteries, which are branches of the thoracic aorta. Therefore, in order to embolize the right bronchial artery from the right femoral artery, the catheter would need to travel to the thoracic aorta and then to one of the intercostal arteries before arriving in the right bronchial artery. In contrast, the left bronchial arteries, superior and inferior, typically originate directly from the thoracic aorta, since the aorta itself is on the left of the trachea and esophagus, right? No one knew what was happening in this question. Only 17% picked correctly, and it was a pretty messed up question. But the concept is clear now, right? You get what's happening. So now the next page talks about the two last really weird big topics regarding respiratory, which are your AA gradient, alveolar arterial gradient, and then the VQ mismatch. And this is the zone 1, zone 2, zone 3 stuff we were talking about in that previous question we just did. Now throughout respiratory, right, compared to my previous respiratory videos, I have a bunch of x-rays that are here and labeled like this to kind of help you better understand what's happening, because AMBOSS did an amazing job with that. So I'm sharing their work with you here, and I highly recommend using AMBOSS QBanks to really get the questions right. And really understand how different x-rays present for different scenarios. X-rays pretty much give away the answer too, right? So let's take a look at what's happening up here, right? This is oxygen deprivation. Couple words here, right? Hypoxia, hypoxemia, and ischemia. We know ischemia already, that's loss of blood flow. What's the difference between these two words? So hypoxemia, any emia like anemia, is something to do with blood, right? So this hypoxemia is partial pressure of arterial oxygen being decreased. So oxygen content in the aorta is less than normal, right? This hypoxemia is different from hypoxia, where you just don't have oxygen. Hypoxia is decreased oxygen delivery to the tissues, either due to hypoxemia or due to other issues like maybe you just have anemia. Okay, so that's the main difference between the two. Hypoxia is decreased oxygen delivery, so some organ is not getting oxygen, hypoxia. Okay, hypoxemia is that your partial pressure of arterial oxygen is low. That means you're not carrying enough oxygen in the blood. That's the emia part, right? You're not carrying enough oxygen to the blood. And if you're not carrying enough oxygen in your blood, then of course you're also going to have hypoxia because you're not going to bring enough oxygen to those organs. And then they list out different reasons things can occur, right? And we have all these numbers to work with, different types of ways to see them, and we have to make sure we know how to work with it. So Sayed's asking, I was wondering, in adrenal insufficiency, we have symptoms related to cortisol and aldosterone. Shouldn't there be androgen-related symptoms also? I think someone asked me this question earlier too, so let's actually tackle that real quick. That was a good question. In adrenal insufficiency, so let's go back and look at it because it's much easier with the picture there to understand it. If we look at congenital adrenal hyperplasia, right? This is very similar to the adrenal insufficiency, right? Because hyperplasia occurs for a specific reason, but we're not talking about hyperplasia. We're looking at this image just so we know what's being made everywhere. Now, when you have adrenal insufficiency, deficient cortisol and aldosterone, what about androgens, right? So androgens are made in multiple places, right? They're made in the ovaries and the testes as well. So it is not the primary function of your adrenal glands to make androgens. It really isn't just your adrenal gland that's doing this, but it is mainly just your adrenal gland that can make aldosterone and can make cortisol. So that's the main reason, first of all, why adrenal insufficiency isn't so concerned with not having enough androgen being produced. The other thing is that if you start making androgens here, right, of course your body realizes that and you make more ACTH and you make a bunch of other stuff too, LH and FSH. They don't talk about LH and FSH in endocrine. Remember, LH and FSH get discussed much more later in reproductive videos, in the reproductive section. So that's where you'll see later on that anyone who's not making enough testosterone, not making enough estrogen, etc., you're going to release more LH and FSH, and then your sex organs, the ovaries and the testes, will just make more androgen. So that can be fixed. That's why in adrenal insufficiency, loss of androgen production isn't that big of a deal. It's not going to be symptomatic. But loss of aldosterone and cortisol is very symptomatic. You need cortisol to deal with stress, stressful life situations, and disease, and you need aldosterone to manage your blood pressure. One of the other things, though, with aldosterone is that in secondary adrenal insufficiency, be very careful. In secondary adrenal insufficiency, your adrenal gland itself is working fine, right? This is secondary. That means that you're not making enough ACTH, maybe. In secondary adrenal insufficiency, you'll still make aldosterone, though, because you have angiotensin 2 over here upregulating aldosterone synthesis. Okay, and you're still going to have all of these other guys here, too, because your adrenal gland is working, right? So if you need more corticosterone, you need more 11-deoxycorticosterone, etc., your adrenal gland can make it. You don't need ACTH to turn this on. Cholesterol does what it is. You need ACTH to upregulate this function, okay? So that's the entire general understanding of that little concept. Very important question. Very good topic to bring up, so I'm glad you asked. That is something that was discussed by another student of mine too, because I'm guessing there might be a new question or something. So good to make sure you understand that. Very important. All right, so now what's happening here? When do you have hypoxia? Right, that's something we saw when we were in cardiovascular as well. Hypoxia can occur because you have a decreased cardiac output, maybe heart failure, so you're not sending out enough oxygen. Hypoxemia, because you're not carrying enough oxygen in your blood. Anemia, because you don't have oxygen carrying capacity, right? No hemoglobin. Or carbon monoxide poisoning, because your hemoglobin, although you have enough amounts of it, is full of carbon monoxide, right? So you have normal amounts of oxygen, you have normal amounts of hemoglobin, but all your hemoglobin is carrying carbon monoxide rather than oxygen. These are the general, most common cases that can lead to hypoxia. What are the things that can cause hypoxemia? Your ability to carry oxygen in the blood is low. Hypoxemia is basically a decreased oxygen saturation of blood. That's kind of how you can look at it. So hypoxemia can occur because of a high altitude. Like when I went to Colorado, it was very hard for me to breathe there because although I was breathing just fine and everything was okay, if I was chasing a dog or going upstairs, I would immediately run out of air, right? And I would have to breathe a little quicker. So I would have to hyperventilate to fix that. And that can occur because in high altitudes the pressures are much higher. Hypoventilation, which occurs due to many things, right? When we were in acid-base physiology and when we were in physio of psych in general, we saw that opioid overdoses can cause respiratory depression and people can die from that. Obesity hypoventilation syndrome, another thing you want to watch out for. People who are so obese that their lungs can't function correctly because there's too much weight on top of it, right? That is a real thing. So you got to be very careful watching out for that. These are two places where you have a normal AA gradient, right? Normal gradient between the alveoli and the arterial, right? What is a normal AA gradient? They didn't really put that here, so I added that. A normal AA gradient is 5 to 15, right? If your AA gradient is higher than that, that means that the difference between the amount of oxygen in your alveoli and the amount of oxygen diffusing into your arterial are very big of a difference. That means that the air is not diffusing, and those are things where you're going to have a high VQ mismatch, a diffusion limitation. No diffusion can occur if the thickness got larger, right, from Fick's law. So fibrosis was the reason for that. And then something called a right to left shunt. This is not a cardiovascular right to left shunt. Be very careful with that. When you get respiratory questions and the answer choice says right to left shunt, they're not talking about the heart having a right to left shunt. This is actually a thing in respiratory as well. We're going to see that as we go on. And so these are things where your AA gradient is going to be more than 15. So an AA gradient of 18, 22, etc. And that AA gradient basically means, looking at this picture again, right, basically means that in your alveolar area, the amount of alveolar P capital AO2 might be 100, but then here in your oxygen carrying capacity of your arterial blood, this might be like 80, right? So then 100 minus 80 is 20. That's a bigger AA gradient than you should expect, and that means that for some reason diffusion is not occurring correctly, right? And it could be because of a ventilation perfusion mismatch where ventilation is okay, but perfusion is not. No blood, so no oxygen transfer. It could be the other way around too, right? Where your ventilation is too high, maybe because you have some kind of machine attached. And it could also be bad perfusion just because of any other reason, like a pulmonary embolism, where you're blocking blood from going to the correct area. All kinds of things. And we're going to see questions on that pretty soon. Ischemia is just ischemia, a loss of blood. You don't have any blood, so you could either have impeded arterial flow, maybe because of atherosclerosis, or you could have decreased venous drainage because of some other reason, right? Whatever it might be. And you can have atherosclerosis of veins too. So whatever the case might be, it'll cause ischemia, but the oxygen levels of things should be pretty normal. So these are just basic things like that. The last thing here on this page is a ventilation perfusion mismatch, and then there's a bunch of questions. I have 4 questions here, and a whole page of more questions and images to help you understand that. So let's actually take a break right here. I'm going to be back in 5 minutes to continue on. I actually want to have all the ventilation perfusion mismatch stuff in one video. And I'm also going to, in the same video, finish up respiratory physio by doing other relevant questions. And then looking at more relevant things that we've been covering so far. And doing the last topic, carbon dioxide transport, using the Bohr and Haldane effect. All right, so thank you very much for joining. I'll be right back in like 5 minutes, and then we'll keep going and we'll finish up ventilation perfusion.